Dr. Rajam Iyer is a distinguished pulmonology and palliative care consultant at Badia and Induja hospitals in Mumbai. She is also a trustee of Pallium India. She holds a prestigious diploma in palliative medicine from Cardiff University, recognized for her exceptional contribution to medicine. She has been honored with Har Gobind Award. She is prolific author with numerous publications to her credit, reflecting her profound expertise and commitment to advancing medical knowledge. Her dedication to patient care and innovation research position her a leading figure in her field. Welcome, ma'am, to the session. Over to you, ma'am.
Good afternoon, everybody. Thank you for the introduction, Gayatri. A very warm welcome to all of you, literally and figuratively, because from where I am, it is really very extremely hot, despite the fact that it should have been monsoon in Mumbai. Today, like Gayatri mentioned, we are going to be talking about palliative care and respiratory medicine as to how and why we should be talking about and integrating the two. One request is to please keep the chat box active so that we can have an interactive session. And an interactive session really makes the session much more interesting. And both of us need to learn from each other. It need not be a one-way communication. I believe you'll have had a few sessions in the past. So without wasting much time, I will share my screen and my presentation. Please do feel free to send your thoughts, comments, etc., so that we can have a session and clear your doubts immediately. So the topic for today, as introduced by Gayatri, is mainly we need to focus on why respiratory medicine should be integrated also with palliative care. Okay, so just wanted to check with all of you. What other symptoms have you already or systems have you already had a talk on? For example, gastro or neuro. Have you all had any topic which is on the palliative care in those systems in your previous 12 sessions?
Hi,
Yes,
all. Please respond.
there is some response on the chat, which is not what I was looking for. But anyway, so the reason why we want to speak about palliative care, more importantly, we should be able to. Are you all able to see my screen?
Yes, ma'am.
Yeah. So, what we need to realize is that unfortunately, historically, since palliative care was started for patients with cancer, patients dying with cancer, very often till date, people in the community, the doctors, the patients, as well as healthcare professionals feel that palliative care is meant for patients with cancer and palliative care is meant for patients who are dying with cancer, which means that palliative care is only for end of life. However, experience and the suffering that our patients go through across the board is clearly proof to the point that palliative care is not just end of life and palliative care is not just meant for patients with cancer. Palliative care is meant for anybody who is not able to cope with their serious illness diagnosis. And it could be even an infection like tuberculosis. So if you see this slide, this clearly shows that in India, non-communicable diseases or non-cancer conditions like diabetes, cardiac illness, cerebrovascular illnesses, chronic lung diseases, COPD, interstitial lung, etc., almost 50% of our population is actually affected by all these conditions. Therefore, if you agree with me, we cannot cure diabetes, we cannot cure high blood pressure, we cannot cure dyslipidemia, we cannot cure ischemic heart disease. What do we do with all these conditions? We control them. We control asthma, we control COPD. So please do remember that as a physician, we are probably able to cure 1/3 of the illnesses. And which are these conditions we are actually able to cure and return patients to good quality of life? Any thoughts? Which conditions do we completely make the patient 100% cured and 100% to the original? Does anybody have an answer? Yes, please send your answers. Exactly. So infection is one thing that we are able to. Thank you, Dr. Dilip. So we are able to cure infections 100%. Having said that, there are certain infections which we physicians have itself made it difficult, which is related to pulmonologists, which is tuberculosis. Unfortunately, with the multi-drug resistant, extremely drug resistant, and totally drug resistant tuberculosis, even an infectious disease like TB, we've managed to make a very difficult mess out of it. So, since more than 50% of our patients in this country are affected by non communicable diseases, most of these non cancerous or non communicable diseases are not curable. We really end up only hand holding them. Therefore, the suffering that the patient and the caregivers undergo through looking after patients of COPD for 10 years, dementia for 10 years, CKD for maybe 8 to 10 years, all these conditions therefore need palliative care. And yes, we do add 1 million of cancer patients every year to our registry. Having said that, the rest are already almost 50% of Indians are affected by these chronic life limiting diseases, and therefore it is very important to focus on the non cancerous conditions. Okay, so therefore, coming to specifically respiratory diseases, this chart is only slide is only to explain to you that number of TB cases are rising. We still have about 28 lakhs of patients of tuberculosis in this country every year. Second, these are people who are between 50 to 15 to 50 years of age, which means they are in the productive age group. And till date, even now, we lose one patient of tuberculosis every minute in this country. So the amount of suffering that goes with the diagnosis of tuberculosis is immense. And what is the definition of palliative care? To address health related suffering. Whatever that patient and the caregivers are going through, we just offer them a hand so that they can bear that journey better. Similarly, with COPD, the indoor domestic pollution as well as outdoor pollution, even in today's paper, there has been a research published by Harvard Medical that how we have losing a lot of patients in the country because of air pollution. So this is also on the rise. And of course, the identification and the diagnosis of interstitial lung disease, which is also steadily increasing in our country. So, given that most of these respiratory conditions are chronic, fairly progressive, and incurable, it is very important to integrate the role of palliative care in respiratory medicine. All of you in your previous sessions must have seen this graph. Okay, this graph is typically how people in the world are dying. So, if you actually divide the way in which people are dying, we can broadly divide into these four graphs. First, of course, being sudden death. For example, cardiac deaths, which typically happens before the age of 50, or accidents, etc., which fit into sudden death, where there is no time to integrate with palliative care. If you check graph B, this is typically of a person who suffers from a cancer illness, where he leads a decent quality of life, followed by that, there is a sudden decline in death, a sudden decline leading to death. And it is this phase that he will require handholding, caregivers require support and symptom control so that this patient has a good quality of life till death and also a dignified death. The topic of interest for today is graph C, which is typical of any organ failure, okay, which could be liver, kidney, heart, lung. Typically, when these patients are diagnosed with COPD, for example, or when these patients are diagnosed with ILD, they are probably at the age of 60 or 65. A patient of COPD lives with his diagnosis for about 10 to 15 years. So typically, if you see, this patient is leading a prolonged period of life with poor quality of life, with a lot of symptoms. And what is his 10, 15 years of life punctuated with? Repeated hospital admissions, either with respiratory failure, with some infection, with ICU admissions. And what do you and me typically see these patients as? We see them as acute admissions in the ICU. When these patients go home, we do not realize the amount of suffering that they have. Are they able to walk on their own? Are they able to go to the toilet? Are they self-caring? Are they eating? Are they depressed? This is something we don't know, and we don't even not even trained to ask. We only look at patients when they come to acute admissions in the hospital. And if you see, when you diagnose a patient to have COPD, it is not perceived as life limiting. We do not, when you tell a patient that he has a lung cancer, in the mind, his next question is, how long do I have to live? But if you diagnose a patient who have COPD or interstitial lung disease, that patient will not ask this as the next question, because he has faith and trust in his pulmonologist that he or she is going to treat him for that. Please remember that COPD is because of an anatomical disruption of the airways, and interstitial lung disease is because of the fibrosis of the parenchyma. These are incurable, progressive, and definitely leads to poor quality of life and a bedridden status. But no pulmonologist ever tells this patient in on diagnosis or eventually in 1 or 2 years of follow-up. Therefore, A, because of the unpredictable course of COPD, and B, because of the fact that it's not perceived as life limiting, we do not manage to integrate palliative care into COPDs, and they continue to suffer and suffer and suffer till they reach the advanced stage and death. The last graph is typically seen in elderly, and now we see more and more people living longer. Every household seems to have an 80 and a 90-year-old. And also the statistics in the next 30 years is quite staggering, where we are going to have an increase for 60-year-olds by 700% and 80-year-olds by 300%. So India is going to be a gray nation. Who is going to be looking after these patients? In a resource crunch country, we really need to sit and discuss death and dying amongst our elderly, and we need to know how they would like to be treated, especially in an emergency. Any questions, any thoughts, any comments? Am I being clear? Are you understanding me? At least you can put a thumbs up in your comments. I mean, in the, if there, am I being heard, Gayatri?
Yes, ma'am.
Yeah. So let's move on. And if you see the top respiratory causes of mortality in the world and in India, in the world, if you can see, LRTI, COPD is quite high. And in the subsequently, in the 21st century, it has continued to remain high, except that TB has fallen because HIV has fallen in the West. But in India, if you see, large part of the diseases, the first 10 causes of death is chronic respiratory conditions. And therefore, as a pulmonologist, there is a lot we can do to improve this quality of death, because so many people are dying because of lower respiratory tract infection, COPD, and tuberculosis. Okay. So, coming to the fact of when you diagnose a patient to have any chronic serious disease, including lung diseases, this is, you can compare it with that patient falling off a chronic disease skyscraper. As the patient is declining and falling every floor, whose onus and responsibility is it to talk to the patients and the caregivers? You and me have seen more patients of COPD, more patients of interstitial lung disease, more patients of CKD, diabetes, IHD. So it is our onus to foresee and foretell. So you need to time the decline and the fall of this patient from the skyscraper with unhurried, sensitive conversations. One thing we are not taught in medical school is to talk. We are not taught how to communicate, and we are definitely not taught how to communicate about death and dying. We never use the word death. We say patient is serious, patient is critical, anything can happen at any time, it is very uncertain, but we never say your patient is dying. So it is important for us to get comfortable with the word death and dying. It is comfortable, it is important for us to be able to see our own mortality, because it is something that we need to remember, that death is inevitable, a bad death is avoidable. So if you as a doctor who has seen more patients of COPD, it is our onus and our responsibility to foresee and foretell, sit down with the patients, talk to them about what can be in sight for them for the future. And because the manner in which you land depends on the way you fall. You can't wait till the patient reaches the first floor and say, now the patient is very serious, we cannot do anything. That is not the time to have the conversation. That is not the time to have a conversation saying, do you want to go to ICU? Do you want to be intubated? Do you want to be given aggressive treatment? You and me both know that if our loved one is in the ICU, nobody has the emotional bandwidth to sit and decide at that time. This has to be done when the sea is calm. You will agree with me that if you have to learn to swim, you will do it when the sea is calm and not in a storm. For that patient's family, at outside the ICU is the wrongest time to talk to the patient. Therefore, what do we want to do? We want to integrate palliative care closer or as much as possible towards the diagnosis so that when the curative care declines, there is palliative care, and palliative care specialist or palliative care team is introduced as a part of the treating member so that it is not that you finish your cure and then somebody else enters. The patient feels abandoned. We need to integrate in our daily life and see to it that there are certain patients who don't cope. They need palliative care hand holding. And it is important to integrate that at as early as possible because palliative care not only supports the journey, it also supports the patient at end of life and supports the family when the patient passes away. Imagine if a patient of COPD has been looked after by the family for 10 years and suddenly is no more. There's a huge void even for the family. So even the bereavement is taken care by the palliative care team. And it's very, very important to recognize when to integrate palliative care. Therefore, a surprise question has been researched in the UK. As a general physician, when you have a patient who comes and sits in front of you, you sit and think in your mind, will I be surprised if this patient is not alive in the next 1 year? If the answer to that question is no, then that is the time to integrate proactive palliative care. And there are two documents which have made this whole indication much simpler. They are the gold standard framework as well as the blue maple document, both of which I request Gayatri to send it to our participants because these papers show each condition and their indication. So respiratory, renal, hepatic, dementia, MND, Parkinson's, stroke, each of these clinical conditions have certain parameters, like I have listed here on this slide for COPD. So if you have an elderly who's had multiple hospital admissions, one ITU admission, is on 24-hour oxygen, requires NIV at night, or has a fall in his lung function parameters. So if an individual satisfies any two of this criteria, it is very likely that he will not survive the next 1 year. And that is the time you need to integrate palliative care. Any doubts or any thoughts? There are some comments on the chat. Okay, they are fine. So please remember, there are very clear-cut indications of when you can refer to palliative care. Because typically, hospital consultants feel very disillusioned. They say that referring to palliative care is like giving up. Referring to palliative care is like a defeat. Referring to palliative care is when it's too early, there is loss of hope. But if you introduce the palliative care team as a part of your team member, as a part of a person who helps you treats the quality of life, addresses symptoms, makes you feel better, it really definitely makes a difference. And that is what we've been doing at the hospital where I'm working in Bombay for the past 7 years. So when you refer to these therefore, the earlier you refer, there is time to build rapport with the patient. There is time to understand the patient, and there is time to understand the values and the beliefs of the family. If you introduce me outside the ICU with the endotracheal tube 2 centimeters away from the patient's throat, that is the wrongest time to sit and say, what would you like to do? The patient will be dead before you finish a sentence. So please remember that timing of referral is very important so that we are able to build a rapport and therefore achieve what we call as goals of care or advanced medical directives. Now, as a busy consultant, it's not easy to do so many things for a patient. Hence, we need to integrate with palliative care. Okay. So moving on, these are the two papers I was talking about, which I request Pallium to share it with you. And there has been research, again, even in the West, where palliative care is way ahead than what it is in India. And research also suggests that more patients with cancer end up getting palliative care. More patients who have got conditions like COPD and ILD end up having aggressive treatments. More of them go on the ventilator. Less of their symptoms are documented, and most of them end up getting CPR, which means even today the mindset is palliative care is meant for cancer, and we really need to change that. Okay. And even if you admit patients of COPD in acute exacerbation into the ICU, what we don't realize is what happens to them once they get discharged. Only quarter of them remain well and alive, and almost 50% keep getting readmitted, and their entire last year of life is punctuated with hospital home, hospital home. Now, how many of us want to actually live a life like this, where you spend more time in hospital, less time at home, dependent on people with tubes in every orifice? There are very few people who actually want that. But do we ask our patients their choice? Yet our ICUs are all full. How many of you know of human beings who pray saying, I want to be alive at any cost in the ICU with tubes in every orifice and with lines in every end? There are hardly any people. I haven't met a single human being, and I definitely don't want to go there. ICU is a place where you admit patients whom you can salvage and return them to good quality of life, not prolong poor quality of life. Where the debate is, are you actually adding quality of life to their life, years to their life, or life to their years? Or are we just delaying death? You need to sit and think why we have become doctors. Are we just delaying death by doing endotracheal intubation, ECMO, dialysis, central line, arterial line? What are we doing? Just because we have it, we use it for everybody. We treat 18-year-olds and 80-year-olds in the same manner. We need to get medical ethics. What is autonomy? Are we doing in the patient's best interest? Are we causing him harm? These questions are important to ask. So, if you see the study of people who've had intensive care treatment, almost 75 patients are dead in the 5 years. Right. So, very often, unfortunately, in cancer, we do have 5 year survival rates. If you see a patient of COPD with type 2 respiratory failure, we don't have any proper data because it's very unpredictable. And because of the unpredictable course, they don't get referred at all. And they continue to suffer and lead extremely poor quality life and suffer physically, emotionally, psychologically, financially, and socially in our country. Okay. So, moving ahead, all of you know when a patient is breathless or an advanced lung disease, what you need to actually do. You need to take detailed history, clinical examination, all the investigations, everything you know. Two things that you really need to focus on is pulmonary function test, arterial blood gas, and 2D echo, because then you realize how advanced the lung disease is. Okay. And the most important thing is think about how this patient feels. The patient has advanced chronic lung disease. He's a respiratory cripple. He's sitting homebound, room bound on oxygen. We need to tap this. It is not just the breathlessness, but it is the loss of role, frustration, anger, dependence, that for even going to the toilet, to wash himself, to change his clothes, to talk to on the phone, he needs help. So we need to ask patients questions differently. How do we ask our patients questions? Is your breathlessness better? Is your pain better? Is your cough better? We end up asking close ended questions. We need to ask open ended questions. We need to ask our patients, what have you given up because of your breathlessness? And that is what opens the Pandora's box. The problem is you and me are not trained to listen to the woes of the patient because you have 50 more patients waiting outside. Hence, you need the integration with palliative care. If you ask a 75-year-old person with Parkinson's, what is it that you have given up because of Parkinson's? He'll say, my independence. I'm not able to go to the toilet on my own. I'm not able to do this on my own. I cannot dial the phone on my own. So many things come which directly affects the quality of life. So we really need to ask patients questions differently so that we can tap about and get into their daily routine, because our patients of respiratory distress are stuck in this breathing, thinking, functioning model. If you have a patient of advanced lung disease, he's breathless because of his pathophysiology. Every time he walks or goes to the toilet, he becomes more breathless and therefore he becomes more anxious. Imagine having a respiratory rate of 30 to 32. The only thing that is active is your mind. So you're scared, you're fearful, you're anxious. So you increase your respiratory rate. Because of the breathlessness and because of the anxiety, now he's scared to move. He continues to sit in one place, and that leads to deconditioning. If you do not use your muscles, you lose your muscles. So the patient becomes even more breathless. So our patients are stuck in this vicious cycle of breathing, thinking, and functioning. What does palliative care do? It lets the pulmonologist look after the breathlessness by treating the pathophysiology. The physiotherapist come and make the patient mobile so that he or she can do activities of daily living with little less effort. So tomorrow, if you and me decide to run a marathon, we can't run 21 kilometers or 41 kilometers the next day. We train to run a marathon by slowly increasing our body capacity. Similarly, the physiotherapist works on the patient so that tomorrow he can walk the 5 steps or 10 steps to the toilet or to the garden or to the dining table, whatever is important for that particular patient. That directly influences the quality of life. I could go to the dining table and eat with my family. I went to the washroom on my own. I played with my grandchild. I talked to my friend. These are the small victories our patients want to do that gives them joy with that severe disease. And the psychologist we involve to take care of the patient's mind. Yes, most patients feel depressed. Tomorrow, if you and me even break an arm or break a leg, it feels very loss of dignity to actually take somebody's help to comb your hair, to change your clothes, to make you go to the toilet, etc. So, breathing, thinking, functioning model is the vicious cycle our patients are stuck in, and palliative care integration with the full team of doctors, nurses, psychologists, physiotherapists, social workers breaks this so that even if we are not able to cure his COPD, we make the journey better. We have a friend, a support, a mentor, because both patients and caregivers need that support. Okay, so that brings us to the very important definition of chronic breathlessness syndrome. So, all our patients with advanced lung disease, advanced cancer, advanced cardiac disease suffer from this chronic breathlessness. And what is chronic breathlessness? A patient who is on optimum medications for his particular condition continues to feel breathless, and that breathlessness affects his psychosocial, emotional life. So, when the breathlessness affects your life, that is when this patient needs the palliative care support. And it is very important to realize that what we offer to the patient is not just dishing out prescriptions. We help the patient plan his life and help the caregiver support the patient by suggesting non pharmacological interventions like positioning of the patient, clothing, ventilation of the room. Some patients need anxiety therapy, cognitive behavioral therapy, music therapy, pet therapy, handheld battery operated fan. So, if you have a patient who is chronically breathless and has an acute on chronic event, just buy a 60 to 80 rupees handheld battery operated fan. Research has shown that by blowing the cool air on the face, there are changes in the respiratory center, and the respiratory rate actually, with serial MRIs, the respiratory rate comes down. So, even this actually reduces the SOS calls to the casualty and the ambulance. So, if you just allow the patient to relax, some breathing techniques, handheld battery operated fan, loose clothes, good position, talk to the patient, encourage the patient, check his oxygen saturation, and then give him treatment, you'll probably prevent a hospital admission. And what we also ask patients is what gives him the most joy, and try to achieve that at least once or twice a week so that his quality of life is maintained. So, non pharmacological interventions for any symptom is extremely important so that the patient feels much more supported. In the pharmacological interventions, again, all of you are aware of bronchodilators, all of you are aware of antibiotics, maybe even antifibrotics, which we give for patients with interstitial fibrosis. And most important thing that we need to realize is oxygen and morphine. Please remember, oxygen is also a drug. Like we saw in the second wave of the pandemic, we should use oxygen judiciously. All patients who are breathless are not hypoxemic. Only if the pulse oximeter shows a saturation below 88, we should put the patient on oxygen. Very often, you might see a breathless patient with normal saturation. That could be anxiety. So, you should not be giving him oxygen, because giving unnecessary oxygen also leads to nascent free radical damage to the lungs. So, please use oxygen judiciously. In a COPD patient whose oxygen saturation is low, if you yank up the oxygen, carbon dioxide may also build up. So please use oxygen judiciously, review the history of the patient, see his blood gas, which has been done previously, and do not use oxygen for all breathless patients. Breathlessness is not equal to hypoxemia. Check the blood pulse oximeter before you yank up the oxygen. And second thing is, how many of you have heard about morphine in breathlessness? First of all, do you know morphine can be used in breathlessness? Yes, no?
Morphine allays anxiety. So sometimes if the breathlessness is related to anxiety, then it helps.
Okay. So good. Thank you for that. Yes. So low dose morphine has been researched in randomized controlled trials also. It's a centrally acting medication. So, like for pain, we do give morphine for cancer pain, severe pain, according to the WHO ladder. But a very low dose, not equal to what we use in pain control, helps act centrally. Therefore, what it does is reduces the work of breathing, increases the tidal volume, reduces hypoxia, and actually improves gas exchange. And like Dr. Kalyani mentioned, because it is anxiolytic, it also reduces that. So very, very small dose we start with. 2.5 milligrams twice a day is what we start, along with laxatives, because morphine causes constipation. And till the first few days, 3-4 days, till the body gets used to morphine, we give the patient perinorm so that the patient doesn't feel nauseous. But please prescribe laxatives, because once a patient with advanced lung disease gets constipated, that is disastrous in the toilet, because he's so breathless and he will collapse in the toilet. So you must prescribe laxatives along with morphine. So we always start low, go slow. And if you do that, there is never any case of respiratory depression. And we do not go beyond 20 milligrams in 24 hours. So there is a ceiling dose also for morphine in patients with chronic breathlessness, if that is the indication to start with. Okay, so this is very important to remember. And one of it is, of course, morphine. And second is how we use morphine in the terminal stage of breathlessness. Most patients, irrespective of their illness, suffer from terminal breathlessness just before they die. And it is important for the caregivers as well as for a conscious patient to be kept comfortable, because as a caregiver, you'll always remember how your loved one passed away. Therefore, it's a concept called as palliative sedation, wherein the intent is comfort. The intent is not to end life. This is aggressive control of patient's breathlessness, a patient who is otherwise going to be like a fish out of water. When the patient has decided no aggressive treatment, no ICU, no ventilator, no NIV, it is still his right to be comfortable. And that is what is achieved by palliative sedation, which we give a subcutaneous round-the-clock infusion of morphine and midazolam so that the patient transitions in peace. Please remember, ethically, medically, and legally, it has to be communicated, documented, signatures taken before you start palliative sedation, because the end result can be death. Typically, it's given for not more than 24 to 48 hours, because that's the phase of active dying. And it's only given so that the patient is in comfort and that the patient transitions in peace. I'm happy to take some discussions or chats on the basis of this, but this PowerPoint is already shared to Pallium and it will be shared to you. So before I move on to other distressing symptoms, is there anything anybody would like to discuss about breathlessness? I can stop sharing and come back here.
Ma'am, I have seen in patients with CL lung, when we
Yes.
give oxygen, they are struggling. Like after removing that, they will be comfortable. Is there anything that we should not be given oxygen for such patients? Or
See, you need to realize to use oxygen judiciously. You should not be put for all breathless patients. You should use oxygen only if the saturation is low. And if you realize that a patient with a particular intervention gets more breathless, please explore his anxiety. What is causing you? Are you worried? Are you thinking about something? Are you anxious? Is there something we can do? For all you know, there could be completely strange thing like, oh my God, I will die before my daughter gets married, or what will my wife do? There is no money left in the house. All these things come to their mind. So please remember, we are so trained to think of pharmacological treatments only. If patient is breathless, give this. If patient has got pain, give this. There could be other reasons. For example, today, tomorrow, you and me have a toothache or a headache. We are not in the mood to discuss so many things. We just want to be left alone. And imagine this patient is going through so much. Nobody stops and thinks and asks him, what can I do for you? What is bothering you? What is it on your mind? We need to explore the patient. We need to explore the patient's mind. And for that, we need time. That's why we need an earlier integration so that we can spend that time. It's not possible for busy hospital consultants to spend that kind of time. That is also acceptable. So, always we have treatments ready for our patients. It could be much more than that. The mind is so busy, the mind is so active, we need to address it. Yes, you and me cannot have a cure for all their problems, but by acknowledging, yes, this can be really distressing for you. I can see that this is really a worry for you. At least acknowledging that with the patient also decreases their issues. That they are heard, that they are listened to also makes a big, big difference to patients. Very often, doctors interrupt patients within 1.8 seconds of the patient opening their mouth. We just don't let them talk. We say it is the patient's history, which is his story. Let him tell his story. And then you can come up with interventions. And every intervention need not be medical. Sometimes just listening to the patient and saying, yes, this can be so difficult for you, also makes a big, big difference for patients. Anything else? Anybody else wants to comment? Can I move on? Yes? Yeah. So coming to sorry, there's some chats. Yes. Okay, fine. So coming to other distressing symptoms, any of you heard a patient of interstitial lung constantly coughing, dry, hacking cough? It's extremely disturbing. So we will talk a little bit of cough, pleural effusion, and hemoptysis. Okay. So it is normally a protective reflex, but when it's persistent, it really can become very, very disturbing to sleep, rib fractures, hernias, incontinence, syncope. So it's important that you also evaluate. Please remember, the cause of cough is not always only respiratory. It could be gastric, it could be cardiac, it could be upper respiratory, it could be foreign body. In children, sometimes psychogenic for attention seeking, and also treatments, cancer treatments, radiation, all can lead to distressing cough. So evaluation of the origin of cough is extremely important. Once you have done all that and you realize it is just constant chronic cough, we realize that simple non-pharmacological things like hot water, lifestyle changes, early dinner, small frequent meals, a little walk after dinner, propped up position while sleeping also helps patients with cough. And recently there has been a paper saying low dose morphine is extremely helpful in actually controlling cough due to interstitial lung disease. So that is very, very important. Second thing is gabapentin, especially when given in the night, because it has a side effect of drowsiness, it actually prevents patients from complaining of cough. So these are the two medications that you really need to remember. ILD cough really works well with morphine, and also gabapentin can be used in very chronic refractory cough. Okay. Codeine is another medication that can be used, but morphine is probably a little more potent drug, again used just like the way we use for breathlessness. Then coming to pleural effusion, again very disturbing, especially in a patient with malignancy, recurrently filling pleural effusions that can cause a lot of distress to the patient and the family. The way we manage pleural effusion is by the prognosis of the patient. If the patient's prognosis is good, you can put a long-term indwelling tube. If the patient's prognosis is not good, which we say less than 4 weeks, if the patient is expected to die, then we just do an aspiration so that the patient feels comfortable and then can give morphine for the refractory breathlessness. So it depends on the severity, it depends on the prognosis and the functional status of the patient. Okay. Similarly, hemoptysis, when you're expecting a patient to be hemoptysis, you should tell the patient that this might happen, that there should be contacts given to tertiary hospitals, because management of hemoptysis is difficult at home and the patient will need interventions like brachytherapy, bronchial artery embolization, cryotherapy, laser, etc., which can happen only in tertiary hospitals. So if you have a patient's X-ray with cavitatory lesions, he's had a few episodes of mild hemoptysis, please give him all the contact numbers when he's well, so that in an emergency, he knows where to go. Okay. Lastly, I would like to touch upon what we all experienced in 2020 and 2021, which is the pandemic. I think if we all were trained, or a majority of doctors were trained in palliative care, we would have managed the pandemic much, much better, because it affected everybody, not just doctors, patients, the whole world. And we realized how much suffering we all went through, and the permanent loss of family members. People were in isolation, people lost livelihoods, and therefore this whole concept of management of grief, bereavement. So if we are all trained in palliative care, we need to have basis of medical ethics so we can triage patients better, select patients better in the ICU, see to it that those patients who we are not able to cure, how we can give them good comfort care even in the ICU, and communication with the patient, the caregivers, what exactly is happening. We need to take that time out of patients who are actively dying. And in the ICU, we need to know the ethics, the legality between withholding treatment, withdrawing treatment, and how we need to communicate. The latest judgment of the Supreme Court in Jan 2023 has clearly stated, if the patient is not in, sorry, if the treatment is not in the best interest of our patient, we as doctors can ethically, medically, and legally withhold or withdraw. But it needs to have proper communication and documentation. Secondly, is we need to push advanced medical directives. Talk to your patients, elders, senior citizens about how they would like to be treated. Document that. There is a draft available on Pallium India website, as well as the Indian Association of Palliative Care on the living will. Yes, the formalities and the logistics is a bit complicated, which has been simplified, but even having these conversations help. It's very, very important that we improve the quality of life of our patients till death. And we must remember that the needs of all people at the end of life is the same. It is irrespective of diagnosis and prognosis. It's not that a cancer patient suffers more, a CKD patient suffers less. So please remember, everybody needs palliative care. And this cartoon is so, so important. We live only once is what, it's wrong. We live every day, we die once, and it is our responsibility as health care professionals to care for our patients even when there is no cure. So with that, I end this. Any comments? And then to the case. Any comments, any thoughts, any questions, queries till we move to the case?
Participant can post your comments on the chat box.
And questions, please.
Should we give bronchodilators lifelong for such patients, COPD and also?
So see, bronchodilators are indicated in airway disease. Very often, any breathless patients get bronchodilators. So you need to arrive at a right diagnosis, whether it is COPD, asthma, bronchiectasis. If you've been able to get a lung function test that documents airway disease, yes, then unfortunately, bronchodilators are like insulin. If you've diagnosed a patient with airway disease, he needs the bronchodilators. And bronchodilators again are best given inhalers. Only advanced stage like gold stage 5 or asthma GINA guideline stage 4 is when you need to give inhalers. The injection, tablets. Injection derifylin is outdated. We do not and should not be using it. Okay, so there are a few comments here before we go to the case about COPD. COPD can be treated. Sorry, what is that? How COPD can be treated for long term. So now this is another separate topic, but typically first is smoking cessation, 2 is bronchodilators, 3 is pulmonary rehab, 4 is vaccination so that they prevent infection. The more active your patient, the better he is. And the typical treatment for COPD is the triohale. So we basically give glycopyrenium along with muscarinic receptor, tiotropium or ipratropium combination along with low dose steroid. So that's a separate topic, COPD treatment. That is something that we'll have to deal with it separately, but I'll definitely share some papers to Pallium who can share it with you, Dr. Urmila. Holistically see the patient exactly when to start oxygen. So there are typical indications. Now, this is a very general question, but there are typical indications for chronic lung disease and long-term oxygen therapy, which we call LTOT. So if a patient's saturation is falling on 6 minutes, make the patient walk for 6 minutes at his own pace, not a running race. And if he desaturates, that is one of the indications for starting oxygen treatment for all activities. Secondly, if the patient has an
Can you hear me?
Yes,
Yes,
ma'am.
ma'am.
Yeah, sorry, my line dropped and I'm dogging through my phone. So where was I? Yes. So I was saying about COPD. Wasn't I saying about oxygen? So that is one. So when the 6 minute walk test shows a desaturation. Secondly, when the patient is overnight oximetry shows that during sleep his oxygen is falling. Third is when the patient has pulmonary hypertension, cor pulmonale, which is high, which means because of constant hypoxemia. So there is, and also at rest, if his oxygen saturation is low, these patients require 18 hours of oxygen therapy. Very often you will see how patients are using oxygen after their oxygen levels have fallen. That has defeated the purpose. You have to prevent the fall and maintain oxygen between 88 to 92. So that is how we treat patients. And these patients cannot use oxygen like, uh, you know, uh, SOS basis. We need to see to it that oxygen actually provides them with good quality of life. It improves their symptoms, and therefore it will. These are specific indicators. Breathlessness is not an indicator for starting oxygen. So you must record oxygen, you must do 6 minute walk test, you must see desaturation and resting oxygen. Gayatri, on my phone, I will not be able to see chat. So if there are more questions, please ask. Please,
Okay, ma'am. Okay.
is there anything more?
No.
Okay. So are we good to go to the case, or is there more thoughts? Any feedback?
I think we answered most of the questions in the chat box.
Yeah. So shall we go to the case?
Yes.
Yeah. I'll mute myself.
Okay. Today the case will be presented by Dr. Tulsi Kodwale, and I am sharing the screen for the same.
Yeah.
Is it visible?
Yes.
Okay.
Hello. Yeah. Can I start?
Yeah, you can start.
Okay. Myself, Dr. Tulsi Kotwale. I am working as a medical officer at CSC Penne under DHS Goa. This is a case of a 74 years old male who is diagnosed as a case of chronic obstructive pulmonary disease in exacerbation, along with hypertension with cor pulmonar with bed sore. Next slide.
One
Next.
second. One second.
Yeah. Okay. Okay.
Is it visible now?
Yes.
Okay.
Presenting complaints were he was a known case of hypertension with COPD for last 10 years on regular treatment. Chronic smoker, stopped since last 10 years. Presented with chief complaints of following symptoms for the last 3 months. Cough with expectoration, breathlessness at minimal activity, wheezing, fatigue and tiredness, bilateral pedal edema, and a decreased oral intake. Next slide. Okay. He's a known case of hypertension with COPD since last 10 years on regular treatment. He was detected as a COVID-19 infection in 2020. He received treatment at private hospital. Following this, there was history of increased breathlessness for which patient underwent repeated hospitalization. There was history of breathlessness even at minimal activity, which resulted in restricted activities of his daily living. History of bilateral swelling of feet, history of abdominal distension, history of decreased urine output, history of decreased oral intake. This was over a period of time. Due to restricted activity, he became bedridden and later developed bed sore at sacral region. Next slide. On examination, he was conscious and oriented. Temperature was normal. Bilateral pedal edema, PT type. Pulse was 98 per minute. Respiratory rate was 30 breaths per minute. BP was 120 by 70. RS, bilateral course and frying crepitations. Bilateral bronchi were there. Per abdomen, soft and distended. Rest of the systemic examinations within normal limit. There was bed sore at sacral region and there was Furey's catheter in situ. Next slide. On investigation, routine investigation, HB 11.5 grams, total count 35,000, out of which neutrophils were 90%, lymphocytes were 10%, platelet normal, serum create was 1.8 milligram per deciliter, sodium was 130, potassium 4.2, sputum routine and culture was negative, chest x-ray was suggestive of haziness or bilateral lower zone, HRCT was done which was suggestive of bilateral bronchiectasis with interstitial fibrosis. Next slide. Treatment, he was on BiPAP with oxygen at 2 liters per minute, duolin and budocort nebulization every 8 hourly, TEP telmisartan 40 milligrams OD, TEP evaporatin 5 milligram OD, TEP Montelukast 3D 1 HS, TEP lacilactone OD, TEP mucomix 600 milligram BD, TEP sildenafil 20 milligram OD, TEP clarithromycin 500 milligram once a week as a prophylaxis, and TEP cotrim DS OD for prophylaxis. TEP pen 40 milligrams OD, multivitamins, cough expectorant, and he used to have receive IV antibiotic during acute infective episodes like injection meropenem and all. In addition, he was on TEP fibrodone OD and laxative also. Next slide. Psychosocial aspect, he was a 74 years old married man living with his 65 years old wife. He has 4 children, 2 sons and 2 daughters. He worked as a painter and left his job after diagnosis of COPD. Well supported by all 4 children who are working in government firm. A jovial person but feels irritated. A little exertion makes him breathless and has to be given oxygen and has to be put on BiPAP ventilation. A social person and his restricted mobility is making him sad. He often verbalizes this that his time is up and he will not be able to come out of it. Next slide. Main concerns are breathlessness, immobility, and dependency on others for his personal care. Next slide. Summary. He's a 74 years old man with a diagnosis of COPD in exacerbation with hypertension with core pulmonar. Next. And discussion points are, what are the effective elements of effective palliative care in this patient? Second is discuss on the other intervention that can be carried out in the patient to improve the quality of his life. And the third one is comment on the role of anti-anxiety and antidepressant agents in palliative care in such type of patient. Thank you.
Thank you, Dr. Tulsi. Ma'am, you're muted.
So thank you very much for that. And after listening to me, you can stop sharing if you can. We have to discuss effects of effective palliative care, other interventions that can be done, and the role of anti-anxiety. Yeah. So we can see everybody's faces. And after listening to me, each of you can probably put a suggestion, about what is exactly happening to this patient. To start with the person who presented, can you start? We can stop sharing, Gayatri,
Okay.
so we can see everybody's face. I remember the questions. So, yes, tell me, what do you think we can do for this patient? So, typically, like I said, and a comment on the chat, it is a holistic care. Any person who is suffering physically will have emotional, psychological, social, financial, spiritual. What is spiritual? For example, often you see patients say with COPD saying everybody smokes, but only I got COPD. Why only I have to get? Why have I got lung cancer? I don't even smoke cigarette. There are no answers for this question, but it is bothering the patient. I'm a vegetarian, I don't smoke, I don't drink, but I've got this cancer. So these are all, they just want to be heard. So every patient, we really need to, hello, can you hear me?
Yes, ma'am.
Hello?
Yes, yes, ma'am.
Hello?
Hello.
Can you hear me?
Yes,
Yes, ma'am,
ma'am.
we can hear you, ma'am.
Yes, ma'am.
My network is really. So, sorry about that. I think my network switched back on the computer. So, what I'm trying to say is everybody goes through it. The point is, you and me in our medical training have never been trained to ask these questions. It's also like, "Arey, if I start asking these questions, I'll never finish my OPD." So, therefore, you need to integrate, and not all your patients will not be coping. Identify those who are not coping, correct? So, what all effective things can you do to this patient? Start by asking simple things like, what have you given up because of your breathlessness? What is it that you're scared about? Is there something you're worried about? Identify the needs of this patient. Does he need a physiotherapist? Does he need a psychologist? Does the family need to be spoken? Sometimes you feel that the family is not understanding me. So you need to have a family meeting. So every patient's need at that particular time is different. So identify, have that conversation so that you can identify the need. Think in your mind if this patient needs to be integrated with palliative care and therefore involve the palliative care team. What we normally do is definitely refer this patient for physiotherapy, definitely for psychology or counseling. See to it that this patient does vaccines. Identify what gives him joy and encourage him to do that. Maybe it's a walk, maybe it's meeting friends, maybe it's having people over. It's different for different people, right? And we don't use antidepressants and anti-anxiolytics very easily to all patients. We definitely send them for counseling. And if the counselor feels that a psychiatrist needs to be involved, then we involve the psychiatrist, and then only antidepressants and anti-anxiolytics are used. So very, very important. The three discussion points were what interventions can be used, how can we improve the quality of life, and also whether we use. Yeah, Gayatri, you want to read it out?
Hello, ma'am.
Yeah.
We have one question from Dr. Ahmed in the chat
Yes.
box. Will a long-term oxygen therapy in the long term will reduce respiratory drive?
I've already messaged, I thought I replied to that message saying that oxygen doesn't act centrally. So it will not reduce respiratory drive. Respiratory drive comes from the respiratory center in the brain. Oxygen doesn't drive that. What happens in a COPD with type 2 respiratory failure is that if you increase oxygen, it actually abolishes the drive because carbon dioxide gets high. So the patient actually gets drowsy. But otherwise, LTOT is usually 1 to 1.5 liters for 18 hours a day so that the patient maintains saturation between 88 and 92. That I thought I replied on the chat. Maybe it didn't go through. Any other questions? Sorry, the person who was presenting the case. So now when you see a patient like this, what will you, what all can you do? There is lots you can do. So when doctors say that I cannot do anything, now it's the last stage, it is actually wrong. You can't do anything to cure the patient, but there is a lot you can do to comfort the patient. And comfort for doctors, unfortunately, is only physical comfort. Please remember, a person goes through a lot of trauma, emotionally, psychologically, financially. In our country, 80% of patients paying through the pocket. And do you know, in the last year of life, 55 million patients go under poverty line trying to keep their loved one alive. So we need to think, why have we become doctors? Are we become God or we are human doctors? We cannot cure everybody. We cannot overcome death. Death is not a failure, it is a part of life. What we need to do is when our patient is alive, we need to be able to give life, add years to his life, not life to we need, sorry, add life to his years and not just years to his life. We need to remember everything, everybody has different wants from life, hopes from life. We need to get to our patient, have that rapport and give what he wants, because finally it is him, right? Medical ethics says autonomy, his life, his body, his decision. It cannot be, in my experience, go to ICU, in my experience, go on the ventilator. It is wrong. You know your body best. Therefore, you should be able to decide what you want. How is it different for a patient and a doctor? Tomorrow we'll be in that same position. Will you not want to make a decision? For patients to make a decision, they need full information. Who is going to give them information? It is you and me. We have to give them information. We have to give them in a manner that they understand. We have to talk to them in a manner that they can decide. We can support their decision, but we cannot decide for them. Very often we get into this thing of, in my experience, you should go for chemotherapy. In my experience, you should do this. But you and I are not getting it done. Therefore, we need to be very honest with our patients, because you and me have treated more patients. You and me are more responsible and more experienced. So it is our onus. And very often people say, but patients get angry. Patients say things like, you decide for me. That is how you have communicated. So you will have some classes on communications also. And that's going to be a huge difference in your clinical practice and in life. How you talk to your spouse, your driver, your maid, your children affects how your life is going to be. So similarly, if you talk well to patients, see to it that you are sensitive, unhurried, because you all know it's very different to be that side of the table. It's very easy to be the doctor sometimes. It's very, very hard to suffer from a prolonged, incurable, progressive illness. It can be really, really debilitating and frustrating. So anybody has any questions? I think I've finished quite early. Happy to take a couple more questions or thoughts or sharing your experiences. Everybody is quiet or already asleep. Gayatri,
Yes,
should
ma'am.
we end the talk? Or there anything more you want to?
Yes, ma'am. Participant.
Can't hear you, Gayatri.
Hello, can you
Yeah,
hear me?
yeah.
Yeah, ma'am. I think we have answered most of the questions and comments on the chat box.
You can share the presentation. You please do share the Blue Maple as well as the gold standard framework. It's there in Pallium in India.
Okay. Okay,
And
ma'am.
any of you are happy to reach out. Yes, somebody's asked leukemia in end of life care with complaints of breathlessness other than oxygen. Can we do? You can definitely try morphine, low dose morphine, 2.5 milligrams. So first of all, check saturation before you give oxygen. If a patient is aware, conscious, then he is obviously very scared of dying. If the patient is young, there are a whole set of problems. The family is young, the children are young, etc. So all those anxieties needs to be explored because anxiety can cause breathlessness, and low dose morphine, handheld fan, all that will help. Please do Google search handheld fan with breathlessness, and you will get a whole lot of research that suggests that a thing under 100 rupees can actually make a patient feel comfortable.
Use of mast cell stabilizers in uh, palliative care.
Mast cell stabilizers. These all too high. Palliative care is very low tech, high touch. None of these things like albumin, total parenteral nutrition, etc., doesn't make a difference. Mast cell stabilizers is for asthma, where there are other many effective drugs, especially steroids, which maintain asthma. Obviously, yes, position makes a huge difference. I did mention that in my slide. Positioning, loose clothes, well ventilated room, music therapy, pet therapy, cognitive behavioral therapy, breathing techniques. Lasix is used only for cardiac symptoms. It decreases the preload and the afterload. So if you have a congestive cardiac failure, then, and that is something that the patient will be on if he's got a poor ejection fraction. Gaurav, for patients requiring oxygen therapy at home, yeah, oxygen concentrators are the best. Only thing, it's electricity. So if a place has constant electricity issues and all those issues, then you need a cylinder. And sometimes the machine can get very hot. So then you need a backup cylinder. But oxygen concentrators are the ones prescribed for people. You can get on rent and you can get to buy. I don't think there are any more questions, Gayatri.
Yes, ma'am.
So I think we can wind up and they can all have early tea.
Yeah.
So thank you very much for interacting. That really makes a difference. I learned. How many of you have access to morphine? My question for the day.
I work in a medical college, ma'am. We have palliative medicine department is there. We have access to morphine.
You're very lucky. Excellent. And you are from Kerala?
I'm from Kerala.
But where are you working in Kerala?
Yeah, ma'am, in
Ah.
Wayanad district.
So you're blessed because Kerala is probably the best place to be to practice palliative care. Everybody, even the rickshaw wala knows what is palliative care because it's community based and panchayat driven. So it's very different. The rest of the country is not that lucky. Anybody else who has access to morphine?
Yes, ma'am. I'm currently working in palliative sector,
Where
Kerala.
are you working?
Like, one hospice,
In,
private. Pukoya Tangal hospice,
in Kerala.
Kerala.
Kerala is blessed. It's God's own country, literally and physically, figuratively. Many of the parts of the country will not have access to morphine. That's why all the more reason that you should be trained in palliative care so they can start under your name, because of it's very diligent to maintain the amount of stock that comes in, that comes go, so that nobody is using and misusing morphine. Have you all watched the docu-series on Netflix called Painkiller? I suggest you all definitely watch that. It's it's a docu-series of how the US has gone the other way of abusing morphine. So yes, we should be careful. India is the largest producer of morphine, and yet Indians are dying in agony across the socio-economic board. Less than 1 to 2% of Indians are getting palliative care. Quality of death index, so the way Indians are dying, we are amongst the 60 worst countries to die in. Even small, like Costa Rica is better than India, a small country like that. Problem is, in India, the state of art availability to put on ECMO, to put on venti, we have state of art solutions for everything. But we put 80 and 90-year-olds, patients with advanced cancer, patients with advanced COPD, patients with advanced dementia, everybody on that. So we need to be we need to more select patients well, and therefore understand the ethos and principles of palliative care better. It's not that we are wanting everybody to die. Everybody is going to die. Point is, we need to see to that people lead a good life and have a dignified end. That is what is more important. Like what I used to hear my grandfather say as a child, Anayasena Maranam, Vina Dainena Jeevanam. Lord, please give me a death without suffering and a life without diseases. This is what our prayer should be. But here we make people suffer and prolong their poor quality lives and say that, we have kept him alive. Did he want that in the first place is something we really need to know. Okay, read this book also, Being Mortal by Atul Gawande. Has anybody read it? So Being Mortal by Atul Gawande. And watch this documentary Painkiller on Netflix. That's enough entertainment now for the weekend. Okay? Chalo. See you. Have a good evening and a good weekend. Thank you, Gayatri. And do share the feedback, because we'll know where we need to improve. All of us need to improve.
Sure, ma'am.
Okay?
Thank you, ma'am, for the wonderful and interactive session. Thank you all for your active participation and engagement today. I hope that all the insights and knowledge shared have been both informative and enriching. We are looking forward to see you on the next session. Have a wonderful day ahead. Bye-bye.